Thank you for this invitation. Thank you for this opportunity of taking stock of the situation. There were a lot of data over the last 12 months that can have an impact on new guidelines that are going to be circulated in 2015. So today I intend to discuss this with you to see how things have developed, to try and anticipate these guidelines. So I have a few recommendations to you. A few things to say to start with, but my disclosures, I've worked with a company producing cooling systems. Now, just to give you the background of the debate, what about the prognosis for those patients who have been resuscitated and admitted in our ICU? It's not the same problem as previously. It's not a cardiac arrest, which is intractable, but it is the issue of patient survival in which there has been new circulatory recovery after admission and after transportation to the hospital. If you follow these patients, if you compare year by year of a large number of patients, you can see that there has been an increase, an improvement over time. There has been an improvement in the prognosis of those patients. So this prognosis improvement, as you can see on the right-hand side, is heterogeneous depending on age, of course, but it is more with younger patients and less with older patients, But there has been something new over the last few years. This is to show you how things have developed. If you follow mortality and survival over a large number of patients, you can see that few of those patients are going to survive without any sequelae. But there has been a change in this scheme, and this can be reviewed because this prognosis has been improved. We can have a better management of post-cardiac diseases, post-resuscitation. And one of the major interventions, not the only one, but one of the event which is originated in this improvement is hypothermia, temperature control. It's therapeutic hypothermia, we can say, not only related to survival after discharge or after a few weeks, but also related to an improvement of the long-term prognosis. You can see if you take 7 survivors cardiac arrest being discharged, these are American patients from the Seattle area. If you look at the future of those patients, depending on whether or not they had therapeutic hypothermia during their hospital stay, you can see that the benefit is related or associated with long-term survival, because this is in terms of years. You can see that even with other variable adjustment, you can see that this survival is quite important. So this management and temperature control is something quite essential in the future of this, for the future of these patients. So this is now well understood by the resuscitation teams. You can see here among this British team, which has started using this therapeutic hypothermia after cardiac arrest. So after the multicentric studies at the beginning of the year 2000 until we had new guidelines, you can see that this has become a usual practice. And the French investigation, and the outcome of which has been presented, or was presented yesterday, we can see that now the majority of us report the use of this therapeutic method in the resuscitation of our patient. But there are still a number of questions to be solved. Now, until quite recently, we lived with what I call the dogma, that of a temperature target, which used to be relatively simple, because in our multicentric studies we had used 33 degrees, a very homogeneous temperature target, and this has shown to be effective, has been shown to be effective in this larger European multicentric study here, ERS. This is a target by which we have built up our recommendations. This is what has been observed in our practice, which is a fast and early cooling as fast as possible, as early as possible, with a maintenance phase during 12 to 24 hours with progressive warming. All this data resulting into an improvement in the future of the patient. But this is being questioned. The dogma has been questioned. We have questions about another temperature target that could be used slightly above, and this is the change that has taken place to move into a targeted temperature control that would target a temperature which would not be normothermia and not hyperthermia, but that would be targeted around 36 degrees Celsius. So the trial that has originated into this change of dogma is the PTM multicentric Nordic study, in which authors have randomized the patients to be controlled at the 33 degrees target, or on the contrary at 36 degrees. So this is maintained during the first 72 hours, and you can see that patients have been maintained into these two targets. The result, the outcome is very interesting, that the authors have shown that with this hard criteria, such as survival, taking the CPC scale, and CPC-5, encephalic death, you can see that this TTM study with 950 patients randomized into two arms, we get a full matching of the outcome or survival for those patients, even if the two targets are very different. And randomization was very good, as the two groups were fully comparable. So no difference, but this is a targeted temperature control with two different targets. So it's not normothermia, or even less no temperature control, an absence of control. It's not just observing how temperature is developing, but it's extremely important. We'll see how this is going to be taken into account in future recommendations in 2015. There will probably be a maintenance of this targeted temperature control. We'll see the role of TTCM and what it will mean in this recommendation. It's quite possible that experts will advise to use a thermal target in this range between 33 and 36 degrees Celsius. So no difference in these subgroups, whatever the initial rate was, whether there was acute circulatory arrest or different times. So the TTCM has not highlighted any difference. So should we think about how to target the patients, when to choose 33 or 36? So far, the subgroup assessment doesn't give us any arguments to move into a different strategy. So we'll have to get extra information to use fully homogeneous strategies and for a better targeting. So ILCOR, the International Liaison Committee on Resuscitation, has taken a stand on this. Recommendations will be circulated at the end of the year, but ILCOR has already suggested, following the result of the TTM trial, that for those who using 33, for which this temperature target is no problem within the team, where procedures are already used, and based on one single trial, until we get confirmation and an extra study, it's not necessary to change your behavior. There is no hazard in using the 33 C target. It's strictly equivalent in terms of side effects or benefits. There is no difference between the two groups. At 33, if you're used to 33 and do it well, you can stay at this level until you get other guidelines. But if you were not doing it already, if you want to start using 36 degree with a simpler procedure, you can also do it. This is why ILCO has taken this stand right away. We'll see whether they go even further in their recommendations. Now, should we do it for everyone? It's not obvious, because there are selection biases which are very, very large, even with the TTM study, even if we don't get a lot of evidence. But randomized trials have studied patients which were resuscitated with atrial fibrillation or tachycardia without a pulse. So regarding the interest of temperature control for the future, this patient has been demonstrated with these patients. But the level of evidence is much less with other patients. Now, for those patients in which we have this level during resuscitation, the level of evidence is much weaker, even with aggregate data from smaller studies, meaning with fewer patients with a non-shockable rate. We can't have a very reliable opinion as to targeted temperature control, or whether it's beneficial for those patients for the non-shockable. It's a way to select a poor prognosis subgroup for which this modality, this therapeutic scheme is less beneficial. This is what has been shown in the Cochin Hospital group, which that were shockable patients. There was a clear advantage. It was odd ratio 2. You can see this in the non-shockable group. You have no improvement in the neurologic outcome and survival rate. So in practice, if you look at what we are doing in our sudden deaths register in the Paris area, which is collecting 13,000 cases in what we call Greater Paris. The first data was published last year. You can see that it's been done patient per patient, case by case. You can see for non-shockable, we only do it 1 out of 2 cases. We're not quite sure that it is beneficial. Of course, there are believers and non-believers, but it will take confirmation data looking at those poor prognosis patients to be certain that this therapy is associated with a true benefit. Should we start earlier? We already knew that based on experimental trial with small animals, rodents, rabbits, when testing the onset, when you test whether it's useful to start very early or after a few hours and how long you apply it, the best outcome is always almost observed with those animals which were cooled early, and almost in all the papers we've seen. So the problem, we are not small rodents. And in our everyday life, if you want to apply cooling very early or in the transportation phase, you don't always observe the same results. you can't relate the good trial results observed with animals, which are in favor of an early use of cooling, and the transformation into clinical results. Even if we have such strong believers that they're prepared to use all the available means. If you have something available, I tend to use it. If I look at published literature, even with a meta-analysis, you can see that if you look at this data, if they're aggregated, if you look at whether patients that were called very early or only when in hospital, it's not in favor of early cooling, but at least with the methods being used in pre-hospital settings. And this might matter too, because it's quite possible that the risk-benefit ratio for early cooling also depends on the technique being used. So with the techniques that we can use at the present day and age, even if there are criticisms leveled at this, but when randomizing a large number of patients, which was done here at the beginning of 2014 in the US, if you stratify randomization between shockable and non-shockable patients, if you cool those patients with saline serum during transportation, which is the simplest method to use, which is the one being used usually, then there is no difference in the future development in survival between patients who had cooling during transportation and those who had only cooling when hospitalized. Maybe you have more side effects or adverse effects with those who had the cooling with vascular filling during transportation, and more respiratory events, maybe. So those who had this cooling feeling had a higher number of edema during this phase. But so far, whether we can do it for patients resuscitated during transportation is not clearly established, but we can consider that with the appropriate technique, you can start this even earlier, be more aggressive, provide cooling during cardiac arrest, during resuscitation. With animals, it's working, and it gives us impressive results, but with human beings, this transformation is not successful. We don't have strong evidence, but we have this randomized studies carried out in the Rhône-Alpes region of France, which was published in Intensive Care Medicine. Patients were randomized either to have a cooling filling during resuscitation, but the main criteria were the appreciation of brain damage with a protein, a marker protein, and there was no significant difference. It was in favor of this practice. So far, and with this technique, but it might change, because it will come a time when we can provide cooling very early in the field during cardiac arrest, but with other method than vascular filling, and then with less deleterious method from the hemodynamic point of view, we can have effective brain protection with the technique being used. But the trial is underway. We can cool the cerebral vascular area with decompression of a very cold gas. We have Renochi. This is a commercial application, and in the pilot studies carried out, very encouraging results were obtained. There are still other trials underway, and we'll see whether such techniques, which may be easier to use, more selective, can give us an interesting result. Should we use this or that technique in ICU? So far, in a nutshell, there is no superiority demonstrated in favor of one technique or the other. We can use the technique that you can better control, but it is recommended still to use a technique for which cooling can be controlled by the patient temperature, systems which are related to patient temperature. with a lesser risk of overshooting or difficulty there is in maintaining temperature, which can be used for progressive warming. So if I am to do cooling, if I can control temperature correctly, it's very important to be cautious about possible complications, which I can show you here in the TTM trial. Whether I choose 33 degrees or 36, it's strictly complications are strictly equivalent. They are not related to cold, but they are related to post-resuscitation syndromes, and not related to cold, but whether it's 33 or 36, I will have infection sepsis, even maybe more so than without any thermal control, which was shown in a retrospective observational study, but in a large number of patients. And it's not a surprise to have such sepsis. It's not only related to cold temperature, but with intubation in the field, with difficult access to airways, etc. Having this cooling will give rise to these complications, so I should be very cautious in spotting them. So cooling can multiply this pulmonary sepsis risk. So should I give antibiotics to this patient systematically? This has not been solved. This is why a randomized study is underway. It is the Prognosis study carried out in Limoges, where patients are randomized into either systematic antibiotics in the first 48 hours after resuscitation, but there are many other things that can occur during the post-resuscitation phase. We can't deal with them all now. It would be too complex. They are well listed, as you can see here, but you should pay attention to metabolic complication, in particular glycemia, dysregulation, which you can observe with these patients. Not only glycemia itself, but how it can vary over time, has been shown here in this trial. So it's mostly the glycemic dysregulation, which was related to an increase in unfavorable outcome for these patients. Now, if I can achieve controlled temperature, I have to give some CARIOU. It's something which should be incorporated into your management, but I won't go into details, as you'll hear more about it in the third presentation. But now today, I'm also aware that there are still many clinical trials underway about hypothermia and its practice under these settings. So things are not quite established, so we will get extra data by which we can refine our strategy for this patient. Thank you. Now available for questions. Thank you for this invitation. Thank you for this opportunity.